afternoon. Quick episode of In the Trenches. My student wanted me to say a few words on SBP, spontaneous bacterial peritonitis. Okay, this is an entity. Obviously, it's seen in ascites, but these patients have cirrhosis of the liver. The only other condition where you could see this are children with the kids with nephrotic syndrome. You could actually see that there also. So if you have a cirrhotic with increased ascites or they're decompensating and you're admitting them, you need to evaluate for SBP. Spontaneous bacterial peritonitis. These patients might not appear septic. They might not have fever. They might not have a leukocytosis. They might not have SIRS criteria. Now, with cirrhosis, the mechanism of ascites is really sinusoidal hypertension. So you have stellate cells in the liver, okay, and they're in the space of DISSE, D-I-S-S-E, and these proliferate and they cause intrasinusoidal pressure and fluid leaks out of the liver into the abdomen, and then you have abnormal Starling forces like low albumin and increased aldosterone due to secondary hyperaldosteronism, vasodilatation, causes fluid to go into the peritoneal cavity. Somebody you're concerned about SBP, you're going to tap them. Okay, there are basically three things you're going to look for: cell count, albumin, and culture. So the cell count, classically, if you have greater than 250 white cells, that's the most important thing. The albumin is more diagnostic for portal hypertension, and this you just see in acidic fluid. You calculate the serum ascites albumin gradient, and the serum albumin minus the ascites albumin, if it's greater than or equal to 1.1, there's portal hypertension. And then the culture, you're not going to get a gram stain here. It's like getting gram stain on the blood culture. Most common cause, E. coli. Next most common cause, Klebsiella. So, you're going to make the diagnosis on admission, often in the emergency room, and then you're going to treat. Usually the treatment choice is ceftriaxone. And then after they're treated, they may need indefinite oral antibiotics. Sometimes you can get infections precipitated by GI bleeds, but that's not exactly SBP. The other thing, you're going to give IV albumin. You're going to give it day 1 and day 3, I believe. Could be wrong, but I think it's IV. You're going to give that and antibiotics, and that's how you treat it, and that's how you make the diagnosis, and that's my quick talk on SBP.